Hello, everyone. Thank you for joining this session on the future of cancer care while you eat your lunch. My name is Alec Stranahan. I'm Senior Biotech Analyst at Bank of America, covering SMid-Biotech. My background, I have a PhD in oncology, so I can at least hang with this esteemed group of panelists. So that's my background. Maybe we can just go quickly on your background.
Sure. I'm Dave Ryan. I'm the physician-in-chief for Mass General Brigham Cancer and a medical oncologist by training.
Hi, I'm Daphne Haas-Kogan. I'm the chair of radiation oncology. And if I told you all the departments, it would take up all our time. So off to Gerard.
Good afternoon. My name is Gerard Doherty. I'm the surgeon-in-chief for Mass General Brigham Cancer and a surgical oncologist by training.
Hi everyone, I'm Kann. I'm a radiation oncologist at Mass General Brigham, and I run an AI imaging lab as part of my work.
Perfect. Well, as you can see, we've got a variety of representatives from, surgery, radiation, medicine. So I think we'll be able to cover a lot of ground as to what the future looks like. But maybe just to ground the discussion a bit, how has standard of care for cancer patients evolved over the past decade? And what does it look like at MGB today, and maybe how will it look different in the future? Dave, if you want to start.
Sure. So I always like to start with the fundamental healthcare promise, right? Which is you're sitting across from a patient, you're a clinician sitting across from a patient, and they want the best chance at the best case scenario, and you have three things that you can do, right? You can give them the best standard of care, the best experimental care, and the best supportive care. And hopefully you're always giving the best supportive care. And your objective is either to cure them, to help them live as long as they can, and to help them live as well as they can. And I would say that what has changed dramatically with standard of care, particularly over the last 10 years, is our ability to cure people, help them live longer, and help them feel better has changed dramatically. And it has developed into a multi-system approach to make that happen. And so I would say that the medical oncologist is kind of at the center at one point, but then backs off. And then there's this rich tapestry of individuals throughout the entire academic medical center who is at one time or another the primary person or persons that's delivering that best chance at the best case scenario. And so when you look at what's happened in lung cancer, for instance, with targeted therapy initially, now immunotherapy, it has changed the way we think about patients in terms of a multidisciplinary approach. And you can't take care of patients without the surgeon, the medical oncologist, the radiation oncologist, but you can't take care of them without the pathologist, the molecular pathologist, the radiologist. You can't do the complex surgeries without anesthesia, the ICU teams, et cetera. And so everything has changed dramatically, and remember, cancer is a disease of aging. And so the vast majority of our patients are older than 50, and they often just don't have cancer. And so the rise of all of the other people has been dramatic. So the onconephrologist, the oncocardiologist, oncopulmonary. We have onco every subspecialty right now, and we couldn't give everybody the best chance at that best case scenario without them. I'll leave you with an example, and then, so for instance, pancreatic cancer. Pancreatic cancer, which is my subspecialty. Now, if you have a localized pancreatic cancer, when I first started, I could count, after a couple of years, I could count on one hand the number of people that actually was cured. If you have a localized pancreatic cancer now, you have a reasonable chance of being cured. And if the surgeon can get it out with negative margins, you might have a 50% chance of being cured. I mean, think about that. When I first started in pancreatic cancer, that just didn't happen. But we deliver all of the chemotherapy, all of the radiation up front, which leaves people with side effects if we do cure them, diabetes, GI side effects, et cetera. But just imagine what it's like for that surgeon to get that patient through the operating room, right? So what happens in the OR? They tear a vessel, the portal vein, the SMV, they have to dissect it off the SMA. They need a second set of hands at a moment's notice to come in, like a real set of hands that knows what they're doing, a vascular surgeon maybe that comes in. They need an ICU attending that knows how to take care of them, ICU nurses that know what they're doing. They need an interventional radiology team that can drain that abscess, right? On and on, but here I am a surgeon, I'm sorry, not a surgeon, talking about Jerry's area, so let me hand it over to Jerry.
Yeah, so Dave's exactly right. I think as we've gotten more better systemic therapies, more ways of targeting cancer, it's made more surgery and more ablative interventions reasonable for patients than was the case in the past. You could have made an argument, people did make an argument when I was in training, that pancreas surgery for exocrine pancreas cancer shouldn't be done, that it actually hurt more people than it helped. And it's not that the surgeons were worse than the surgeons are now. The surgeons may have been better. Two things have changed, but the main thing is the fact that we have better systemic therapies now that enable us to control the edges, control the systemic disease, and make the surgery more reasonable. The other thing that's changed is all of those other adjuncts that Dave talked about. So at the Brigham, where I spend most of my clinical time, and it's the same at Mass General, about 25% of the operations involve more than one surgical specialist. So it's not just a cancer surgeon, it's a cancer surgeon and a vascular surgeon, or a plastic surgeon, or a thoracic surgeon, or all four, getting together to try and solve some complicated operation that might not have been reasonable 20 years ago, that has now become a part of the standard treatment that people can benefit from. When they leave the operating room, Dave's right. Sort of, part of our responsibility is in surgical specialties is to get patients through the operation after they've had that done. And all of the adjuncts we have in a full care hospital now make that happen much more than it ever used to. Our surgery is much safer now, even when it's more complicated than it was in the past, because of our safety things in critical care medicine, our safety aspects in interventional radiology, being able to take care of small complications with less invasive means. So I think the standard of care has changed a lot, but I would say I would attribute a lot of it to the more effective systemic treatments.
I'll build on that and say that now, and even more so in the future, cancer care is going to be more nuanced and coordinated and complex in two main ways. The first was already highlighted by Dr. Ryan and Dr. Doherty, and that is that the patient, of course, the patient's initial task is to deal with their cancer, with a radiation oncologist, a surgeon, a radiologist, a pathologist, a medical oncologist. But then that patient who might, let's just give an example of a breast cancer patient, they might get their care at the academic medical center. They might actually get their care at an affiliated community hospital. But either way, that patient is going to have lifelong issues to deal with, be it from the actual cancer, or because that person's getting on in age, or actually because of our treatments. So it goes so far beyond the actual oncology care team, and it includes everybody at our hospital who is expert, be it the orthopedics for the woman who's taking aromatase inhibitors and now has issues, joint issues. And it goes on and on and on. So the holistic approach to the entire patient in the moment, but also going forward for the duration of their life, is critically important. And I love the way Dave phrased it before, that we as oncologists become a part of a very, very complex but beautiful tapestry of care going forward. So that was one example. The other example is that both Dave and Jerry brought up things like targeted therapy and immuno-oncology, which is, of course, much of what the future holds for us. But we have a much more nuanced understanding of what that is. Before, we had such a laser-eyed, a focused view of which compartment in the immune system is important and what should we be following. But we understand now that the extracellular matrix for any tumor and the other cells are so critically important, and they have to be attended to as we develop these new therapies. So for example, there are beautiful investigations now that show that yes, a brain tumor cell and the mutations therein, the mutation that brain tumor cell has incurred, are very, very important. But the neurons around that brain tumor cells are critically important. And there are some investigations that show that as we think, as the neurons fire, as we think, we might be actually signaling to the tumor to grow. So it's never just the tumor cell that we're targeting. We're always targeting a much more complex milieu, and that's going to be more and more evident as discoveries progress going forward.
And I think these are really beautifully illustrated points. And I would just add, I think, in terms of the advances in systemic therapy, which have been really dramatic and changing the standard of care over the last 5-10 years or so, it's really changing the way that we think about metastatic disease. Instead of seeing it as kind of just this all or nothing, you've got metastatic disease, you don't have it, we're really seeing it more as this spectrum. As our systemic therapies advance, as we're identifying targeted mutations that we can put patients on with very effective, low toxicity treatments, the lifespan of these patients is extended a lot more. But what invariably can happen is, there can be a few resistant clones at the primary site or in a metastatic site. And what I see as a radiation oncologist a lot now is patients who come on these incredibly effective therapies have been doing really well for maybe 6 months, a year, 2 years, but then have a site of resistance. We can target that with radiation or sometimes surgically, and then allow those patients to stay on that low toxicity treatment for a lot longer. And that's, I haven't been practicing for all that long, but that's really, I think that's really a new paradigm that's developed in allowing us to really deliver effective treatments for these patients, even with advanced disease.
Oh, that's great. Definitely a lot of interesting future directions here. And I think one that I'd like to turn to next is AI machine learning. And I just moderated a session on AI to a packed room. So there's definitely interest on how we can apply this tool, and I emphasize the word tool, to oncology. You mentioned diagnosing, staging, patient treatment matching, but data is obviously a problem in packaging that data as well. So Dave, maybe if you want to touch on that first.
So I like to think all of life is risk stratification. I was driving down, I'm now a grandfather, I was driving down with my 3-year-old grandson, and we were going through a beach community that was 20 miles an hour, and then we had to drive through the woods, and he was like, go faster, Grandpa. And I was like, no, it was nighttime or evening, and I was trying to explain to him how deer just jump out into the road, and the risk changes. It's not people anymore, it's different. And I think when I think about AI, I think principally about that fundamental healthcare promise or transaction when you're sitting in front of a patient and helping them to determine what they should be doing next at any point in their journey. And as a physician, you're constantly trying to risk stratify for them. Between the millions of different options, it seems, that you can go down. And I think that for those of you who don't know or aren't practicing clinicians, when you're sitting in front of a patient, the button that is getting the most filled up in their chart, and we're now almost all on Epic, almost, so I don't want to push Epic, but it's the media tab. You hit their media tab, and their molecular pathology, from their germline, from their ctDNA, from their imaging studies, special pathology reports, every special consultation that was outside of the system is in a media tab. And it's like doing the old-fashioned, when I started, the old-fashioned chart biopsy, when I was at Columbia as a resident and you got a consult, and you got the old chart, somebody would dump 3, volumes on your desk, and you had to go through it at 3 a.m. in the morning to try and figure out what those blood cultures from 2 years ago showed. And it feels that way again. The human brain just can't manage the amount of data that is coming at us, and we need to be able to risk stratify. So I would say, as a clinician, I'm looking forward to the ability to collate this data in a way that allows us to target the next therapeutic option for that patient. Even if they're in survivorship and we're searching for a new cancer, or we're searching to figure out, are they going to get severe osteoporosis? What we're using right now is not adequate, and I think that's the main thing that I think is going to happen in the immediate future for AI.
So I'll build on that and say that there are things that we're using already in the practical space, and then their aspirational goals. So I'll give you a couple examples in today's, what we're actually using now. So for 100 years, maybe not quite 100, but close. Let's just say we're treating a man with prostate cancer with radiation. That man for weeks and weeks and weeks will get the exact same field of radiation day after day after day. But from 1 minute to the next, from one day to the next, and for sure from one week to the next, it's possible that the gentleman has more urine in his bladder, or a gas bubble is passing through the patient's rectum, and the anatomy actually changes. And we had zero capacity to make any changes. And AI has now allowed us to make on-the-fly changes. When this gentleman lies on the table, we can quickly scan and see what the anatomy looks like, both from a tumor perspective, but also from normal tissue, from the normal tissue perspective, and we can, on the spot, with the use of AI and a sophisticated physicist and a sophisticated radiation therapist and physician, we can actually change the plan in just a matter of seconds and deliver a more appropriate plan that day. And we can do it the next day and the next day and the next day. That was never possible. Without AI, it would take hours and hours and hours to generate such a new plan, but that's possible. Another example is a woman with breast cancer. And when she gets radiation, and especially if she has a left-sided breast cancer, there is going to be some heart in the field and there's going to be lung in the field. But at MGB, we have generated an AI-driven model for auto-contouring the heart to assess how much radiation that woman is going to get to her heart and how to minimize any long-term toxicity to that woman's heart from radiation and to her lungs. Because she's going to live another 60 years or 50 years or 70 years, whatever it is, and we want to make sure that we're not increasing her risk of toxicity from her treatment. And the last example I'll give is individuals who have other healthcare toxicities. They're homeless. They have financial toxicities. Those are things that are just impossible for a human brain to drag out of a 3-foot high file. And going forward, it is very hard to follow every one of your hundreds and thousands of patients and make sure that you're on top of whether they have housing, whether they have the supportive care that they need, whether their financial situation has changed, their insurance. And natural language processing is also being used to identify these other toxicities, important toxicities, so that we can know to call a patient and say, hey, I see that you might be homeless, let's help you. So those are ways in which I think AI is already helping us and is somewhat aspirational. And one of the most exciting things I'm going to let at the end, I think Dr. Kann is going to tell us some of his work, but go ahead, Jerry.
So Ben, you're the AI expert. Why don't you go next? I'll clean up.
So yeah, I mean, I think there's little doubt that AI is really going to touch on almost every part of the cancer care journey, from screening through treatment, follow-up, surveillance. Just in thinking of like a framework, when I think about AI as a developer and kind of as an evaluator, I think about the use of AI to make impractical things practical, and then on kind of the other end of the spectrum, use AI to make impossible things possible. And I think Daphne and David already touched on some of these aspirational versus what we're using AI for right now as we speak. Certainly, trying to kind of remove the laborious, mundane, rote tasks that we as physicians spend a lot of time on, to our dismay. AI is already helping there in the clinic now to help alleviate that. For radiation therapy planning, contouring is a great example where we're using AI-generated contours now to save hours of work, where we're behind the computer basically segmenting out these tumors or organs for the body Beyond saving time, we think that AI can also serve as a quality control check for, for the wide amount of subjectivity that we get when we do these different contours, and really help standardize the way we treat patients, even in places where maybe the level of expertise or specialization is not as great. So I think that's an area where we're already using AI. We're piloting out AI, natural language processing techniques coupled with audio recordings to now auto-document the notes that we spend so much time in front of the EHR doing, allowing us to really get more face-to-face time with the patient, not going between the computer and the patient, back to the computer, taking notes. So I think these are all kind of these, making things more practical. In the kind of my areas of interest in using imaging, a lot of them kind of cross over to this. How can we actually use AI to synthesize data within images, whether it's radiographic imaging or pathologic imaging, to deduce things about tumor cells, grossly or under a microscope that we simply aren't trained to do as clinicians or diagnosticians. We take for example, the pediatric brain tumor world, where for pediatric glioma, maybe there's 1,000, 1,500 cases in the country every year. So there's just no way that a radiologist or a clinician at one given institution is going to have a plethora of experience treating and diagnosing these. But by pooling large data sets together from multiple institutions, we can develop algorithms that analyze these tumors on imaging and can actually predict things about them that we can't do with the human eye. Are these going to recur? Are they going to recur within 5 years, 3 years, 1 year? Will they benefit from certain treatments? We can actually, beyond even just risk stratification, we can develop predictive algorithms that will say, well, this patient might respond to an adjuvant targeted therapy more so than this other patient. We're also starting to develop algorithms that look beyond a single time point and actually are able to look at longitudinal imaging. So a patient gets a resection, has a brain tumor, then we follow their images. These patients are subject to every 3 months, 6 months imaging for years and years and years. We can collate all that data, and as a human trying to rifle through all that data and make sense of it, it's extremely difficult and time consuming, and again, we just don't have that much experience doing this kind of thing. Whereas an AI algorithm trained on the right amount of data, we're showing can actually ingest maybe 10 time points of scans and then use that information to predict what's going to happen on the next scan. Is that patient going to be at high risk or low risk? And maybe the patient at very low risk, you don't have to subject them to quite as frequent imaging, or on the other hand, the patients at very high risk, they might need to start early initiation of a treatment. So those are just some examples that come to mind.
So my interest in AI is actually to use it to try and scale our best quality care across the system. We, as a system, take care of patients one at a time, but we want to do it for hundreds of thousands of patients that come through Mass General Brigham, often with similar problems. So I know now if I have an acquaintance with pancreas cancer, I can set them up with Dave, and he can go through all of that information, go through all those PDFs in the media tab that he was just worried about, and he can make a state-of-the-art, guidelines concordant set of decisions with the patient about what the path should be going forward. What I would like to do is to be able to scale Dave to the rest of the system, so that no matter where in the system the patient comes in, that they can get an approximation of that same kind of guidelines concordant and really top of guidelines care. And not only that, that our system would be able to pick out who we don't have an answer for and that would be appropriate for a research protocol. And so I think if we can do that across the system and not be dependent on Dave's clinic schedule, we will have done a great thing for our population.
So no autonomous robo-surgeons?
Not yet, no.
Not the near future, at least.
It's more like drone surgeons. We still have to drive them.
Okay.
Yes.
Yes, that's good. I feel relieved. I want to turn now to progress in maybe areas of opportunity in the future, focusing on tumor types, right? We've seen practice-changing impacts from immunotherapy, right, across the spectrum that you guys have talked about. What are some tumor types that are making the most progress in terms of improving patient outcomes? And maybe as a follow-up, are there any tumor types that are being left behind? Maybe starting with Dave.
Yeah, sure. So, I mean, obviously the tumor types that have made the most progress, I think, are are the big ones, right? So lung cancer right now is dramatically different than where we treated people 10, 20 years ago. They've been one of the most successful benefiting from the targeted and immunotherapy revolutions. Breast cancer is phenomenal. You're expecting people now to live 10 years, hopefully with metastatic disease and even beyond if we can get more investigational agents coming into clinic. I think that there are a bunch of tumor types, though, that have been left behind. And if you think about metastatic pancreatic cancer, if you think about metastatic colon cancer, these are tumor types that are probably, particularly colon cancer, are a range of different illnesses from the rectum all the way to the right side of the colon that we haven't had tremendous progress, I would say, in the last 10 years. And one of the things that AI will allow us to do is to figure out what are the differences between these different colon cancers, what might they be, what might we be able to target. When we think about immunotherapy and where investigational agents are going, what are the tumor antigens that the T cells, at least at a time, were responding to, and can we augment that T cell response with either standard immunotherapy, with T cell engagers, or with cell therapy? So those are the kinds of things where we think where we're placing our bets on the investigative side and trying to move the field forward.
So I would actually go to the other end and say we've made some progress there as well, and some of the cancers that we now diagnose but don't actively treat. This idea of active surveillance for some tumor types. Probably the two most prominent are prostate cancer and thyroid cancer, where our ability to diagnose these tumors at a very early phase, when many of the tumors will never become a problem. Our initial reaction to that information was to do surgery or radiation or something to essentially over-treat a lot of people. And I think over the last decade, we've gotten much smarter about not treating some of those folks.
So I'll go to the other spectrum and talk about diseases where we've really struggled. And not necessarily because we've left them behind, but for reasons that I'll touch upon. So looking at brain tumors, which is actually what I treat, in adults and in children. So I think what's so challenging about adult brain tumors is that they are so genetically complex. And even when we know there's a single driver, let's just say a high-grade glioma that has a particular mutation in the epidermal growth factor receptor, the V3. 10 years ago, 20 years ago, when I entered the field, everybody thought, fabulous, we have a driver, we can go after this driver. And yet we've made very, very little to no progress on effectively prolonging life, and for sure, we've made no progress on curing patients, even when we know what the driver is, and even when we have ideas of how to target that driver, because these brain tumors are so genetically complex. And I think there, where we have made enormous progress is understanding the nuances and the differences in genetic makeup of these, and in how to use a more comprehensive tool. So for example, CAR T cells, perhaps it's cell therapy, along with an understanding of the extracellular matrix and how to target the extracellular matrix, that's going to help us target these tumors that are so genetically complex that even though we thought we would be able to, catch them when we have the driver mutation, we've just failed at every turn. Conversely, are pediatric brain tumors, where they are very genetically simple. So when investigations have found a driver, we've been extraordinarily successful. It's only a few months ago that work that came out of Harvard Medical School, MGB, kind of our global community here in Boston, the first ever agent to be FDA approved, targeted agent for a pediatric brain tumor, was recently approved by the FDA. And that came out of investigations here, and that was possible because pediatric gliomas, in particular lower grade pediatric gliomas, are much more genetically simple. So when our scientific investigations did identify a driver, and we figured out how to get an agent into the brain, big problem, and how to target that driver, we've done great. And we have had children, I'm not exaggerating, saying decades, on some of these agents with very limited side effects, and children doing great. In the past, when I trained, when I was early career, we would have given that child radiation. And that child would have incurred all the side effects of radiation when you radiate a 2-year-old or a 2.5-year-old or a 3-year-old. We never do that. We almost never have to do that anymore because of scientific investigations and discoveries. So much of what has been done here in our community. And actually, Ben, you're one of the people studying these.
That's right, yeah. No, I'll provide some additional context through the lens of AI, which is why I'm here. But essentially, I think that there's kind of one kind of real opportunity and then one potential opportunity, but also with a little bit of a cautionary tale. But I think, we've highlighted that a lot of these cancers that are screening detected, whether it's mammography, PSA for prostate, lung cancer, CT screening, when caught early, they do extremely well. And a lot of the cancers that have gotten left behind, in my view, are the ones that are not screening detected or that we cannot detect early enough. So I think that AI has a real opportunity here to help with this. There's been a few, whether it's just from a more, the kind of, you want to call it a simpler approach, is to just make screening more sensitive and more specific, kind of reduce the number of false positives and false negatives that we get from these screening exams. And one such model developed at MGB, it's this Sybil model for lung cancer early detection on CT screening, has shown to do just that, and that's being rolled out in prospective evaluation currently. There's also been advances in mammography, again, limiting improving sensitivity, improving specificity of these exams, and I think all of that will help push more patients into the earlier stage, more curable setting. And then some really interesting, more kind of complex, maybe a little bit more out there things that are happening right now is, for pancreatic cancer, well, we didn't even touch on serum-based or blood-based assays for early detection, which is certainly another area. But just in terms of AI, a group here and some others are looking at EMR mining to basically tease out signals that are going to predict a patient developing things like pancreatic cancer, within a couple years. So the idea being, by capturing certain signals or the incidence of ER visits, lab values, that in and of themselves we can't really understand as a signal that triggers, dedicated diagnostic testing. But if the AI can find that, risk profile, flag that patient for early testing, it could really make an impact. So I think there's going to be a lot of potential there. I think on the other end of the spectrum, in talking about the areas that are left behind, like brain tumors, certainly AI, as we've talked about, can be used to better risk stratify these patients, to try to predict which ones are going to respond to therapy, which ones might not need therapy, and that's a huge advance. But I do think the main limitation there is what AI can't really do is create the new treatment for you. And I think we have, thankfully, cancer biologists and other folks to really do that, and we've had great success in the story that Daphne was talking about. But I think AI will help us as these developments come out of the translational basic science labs. I think AI will help us find the optimal use for them and select the best patients for the best treatment.
And maybe a follow-up to what Ben was saying, and this is a question we received from the audience, so thank you. How will precursors from risk factors due to lifestyle and environment be considered in the prevention and screening frequency for patients?
Yeah, I think that's a huge area of investigation, and that is, I think we're going to see a sea change in the next 5 to 10 years. I think, if you look at screening guidelines now for lung cancer, for instance, you've got pack years, age. I'm not getting them all off the top of my head, but it basically comes down to that. Mammography, age, that's the criteria for screening. Colonoscopy, age, family history, or maybe some genetic mutations. But we're really not doing this in a very kind of precise or granular way. And so I think, and that's again, it's kind of just an artifact of what's been practical, easy for us to understand and implement at a wide scale. But I think as we start implementing these AI algorithms, whether it's, a lot of it I think is going to be analyzing electronic medical records combined with imaging data, lab data. There's some stuff out there about looking at even like internet search history. That's kind of outside of my wheelhouse, and I think outside of the our IRB approval, research protocols. But I think there is going to be a combination of these things that really helps optimize who gets screened, who doesn't get screened, and finding the right patients to get screened early, and all of this hopefully, again, improving detection of early malignancy that can be cured.
I could give you a really good example working off that. So not to scare you guys, but colonoscopy is not that effective for right-sided colon cancer. So the hazard ratio of dying from a left-sided colon cancer if you've had a colonoscopy is essentially about 0.2. I'm sorry, 0.8. So you have an 80% risk reduction from dying from a left-sided colon cancer. It's somewhere between 0 and 0.2 for a right-sided colon cancer. So imagine in the future if you get a colonoscopy and you get a random biopsy, and that random biopsy is now processed digitally and subjected to machine learning algorithms to say, does that area of normal colon have the ability to make a cancer? Then link that up to a digitally processed CT scan on that particular patient. Then link that up to a digital next generation plasma-based sample that has not only their germline, but their circulating tumor DNA, their epigenetic with methylation markers, and their proteomics. And now all of a sudden you have a candidate to say, there is a colon cancer in there, or there's an early cancer that's about to appear, and you guys just haven't found it yet, right? So that changes everything. And then layer on top of that somebody with, say, metabolic syndrome, where we already know they're at increased risk. But which metabolic syndrome? Because not all metabolic syndromes are the same. And so this ability to change how we look at each individual patient and bring together the system to take care of them is going to dramatically change in the next 10, 20 years.
Interesting. Would you say that data is available today and it's just a matter of connecting the dots using machine learning, or do we have more to do on the data side?
I think we have more to do on the data side. We don't understand the tumor microenvironment, particularly on the immune side. So working out those single cell transcriptomics, we're just starting to understand the architecture, the spatial transcriptomics of cancer and normal tissues and what the processes that they undergo next to each other. And I think from a prevention standpoint, that's going to have a huge, because right now we're talking about, when you're looking at ctDNA or any of those plasma-based platforms, you're talking about detecting a cancer already. You're not talking about preventing it, right? You see the cancer, you just can't find it yet. And you're using imaging to find it. What some people want to do is say, okay, am I at risk, at higher risk than somebody else for getting that particular cancer, and how do I target that risk?
Interesting. So along this line of thought about detection and care decisions, another question from the audience: with the increased presence of blood-based MCEDs and legislation possibly supporting them, how does this impact possible care or early detection? I don't know.
So we've started our fastest growing clinic at Mass General Brigham as an early detection and diagnosis center. And so a couple of things. So one of the great things about doing what we do is you get to see these trends before everybody else sees them. And so one of the trends that's happening is it's really hard to work up a cancer. A lot of internists don't feel comfortable working up that cancer. And so should I biopsy that? Who biopsies that? It's the role of the old general surgeon in the community hospital that used to take that on. And so we needed a place to do that. We also needed a place that could integrate germline genetics. Somebody who's very comfortable with understanding what a germline genetic profile looks like, what they're at risk for, and then implementing these plasma-based assays and trying to figure out if it's positive, where is that cancer? And if it's negative, is it really a true negative? And are we screening that patient and not doing any harm by that patient thinking, oh, I don't need to be screened now, and I'm going to forego my mammogram or colonoscopy, et cetera. But the person who becomes the least important is the medical oncologist, right? It's the pathologist, it's the surgeon, it's the radiation oncologist. Is it that lung nodule? If so, can we ablate it? Do we cut it out? Do we really need immunotherapy or chemotherapy for a 8-millimeter lung nodule? No. And so the medical oncologist now starts to take a back seat, and the pulmonologist, the radiation oncologist, the surgeon, they all of a sudden move to the forefront in that tapestry of the system. I don't know, Jerry, if you want.
Yeah, so there's also a flip side to some of these serum-based testings, and Dave and I have had this discussion along with some other faculty members around MGB. First of all, I'll caveat this by saying that the current tests are probably not the final tests, right? The tests are going to get better and better, but the current tests probably have too much overdiagnosis and over-testing, and we're going to prompt a bunch of scans. They're going to find little things, and then we're going to biopsy them or follow them or do more scans. We're going to create problems that might be as bad or worse than the cancers we detect. And so I think this is an active area of investigation that we still need to pay attention to. It's not settled business at this point.
Those are great points. In the minute we have left, and I think it's a great opportunity given we have representatives from many of the treatment verticals at MGB, but how does interdisciplinary, going back to something Dave said in the beginning, how does the overlay between your different departments and the cooperation, how does that improve, evolve, and what's the benefit for patients from that?
So I think traditionally this is the role of tumor boards, right? You know, in the original, a tumor board is essentially a regular committee meeting that has experts in the treatment of tumors that consider individual patient scenarios and try and standardize or provide sort of best available consensus for moving forward for that patient. I think we have like 26 different weekly tumor boards because there's every subsegment of disease that you can imagine, pancreas and thyroid and brain and so on. I think the future tumor board will look very different from what it looks like now, and I think it's going to be much more dependent on our pathology and radiology colleagues and interpreting their digital images to help people like me and Dave and Daphne and Ben understand this particular patient's condition and what's going to be best going forward.
It's ultimately all about the people, and I think going forward, the vision of MGB is to have people structured around a disease, let's say lung cancer, but an enormous and varied number of experts that were already mentioned. And the tumor board of 10 years ago would have had radiation, surgery, medical oncology, and mostly a pathologist and mostly a radiologist. Now we have a molecular biologist there, and we have a molecular tumor board where the scientists also join and talk about the best targeted or the best immunotherapy approach, and the breadth of expertise at a place like MGB, not just in cancer but way beyond. People like Ben, experts in AI, I think is where the future is the brightest for all people who need to be screened and might in the future be afflicted with cancer, but also for patients now who are afflicted with cancer and want to be cured and then live many wonderful decades of quality.
And I just, again, through the lens of AI, just quickly, I think, part of that revolutionizing and transformation of the tumor board, I think, will be in part driven by having the ability to use some of these tools, some of the imaging-based tools that I've mentioned, if you're in the generative AI talk, some of the histopathology-based tools, which are really exciting, allowing you to interact with the digital pathology. We're going to have these tools available to us. We're going to have, when we discuss these patients, there's going to be added information overlaid on the images, about the tumor, about risk, about certain things about this patient. We'll have added information about the pathology. And I think it's really going to help, with efficiency, help us streamline our recommendations and ultimately give better quality recommendations too.
Before Dave closes us out, I'll just add that the bright minds are ultimately as important, but honestly more important, because I was just at a tumor board last week, and there was a lot we were going to do with that tumor. And we were going to send it out for methylation studies, and one of us said, what are you going to do different based on this information? And everybody took a pause and said, nothing. So we were like, well, let's move forward with what we know this patient needs now. We don't have to wait the 4 weeks for methylation studies to come back. So always taking a moment to think and analyze, and we work with the most expert, also kind, caring, and thoughtful and collaborative individuals I can imagine ever working with And that's what it takes.
Yeah, the administrative burden of managing the people is enormous. I think that the tumor board of the future is a prime example. It's just bringing everybody together. And it is the one thing about the pandemic that came out of it, they're all on Zoom now. And it used to be, you would go to the senior clinician and say, what do I do for this patient, that I have now? And now you can't wait to get to the Zoom tumor board. So I'll give you an example. On Friday, I was actually traveling, but dialed into our hepatic tumor board because my patient with liver cancer was progressing on his third-line therapy, but he had liver-only disease. And in the tumor board, I had his hepatologist, there was a transplant surgeon, a liver surgeon, a radiation oncologist, an interventional radiologist, my other medical oncologist, and the representative from the phase 1 group who was, going through the molecular profile of that particular patient. I can't take care of that patient without that team. And we are now going to have to start a second day of liver tumor board because we couldn't get through. So as an administrator, I was sitting there going, how do we organize this to do a second day? How do I get everybody there? And I didn't even mention the radiologist who was actually running the program. So that's the future of tumor boards, and the future of a medical system is going to be able to organize those people so that they feel like they can thrive in that environment.